Recording.
Alrighty, everyone. Hello and welcome to part 3 of 3 of our NCLEX Prep Med-Surg review. In today's review, we're going to be covering neurological nursing, disorders of the eye and ear, musculoskeletal, some hematology, oncology, immune and infectious disease, and critical care nursing. Again, this is not going to be 100% in depth of the neurological system. If you're looking for a review to help you with your nursing classes, I have tons of reviews already posted for that. This is going to be an NCLEX review where we are going to hit on the main points and the main topics, such as tests, results, nursing interventions, etc. So without further ado, we're going to go ahead and get started. So up first in our neurological nursing segment, we're going to talk about our main cranial nerves that we are concerned about as nurses. We have our trigeminal nerve, our vagus nerve, our glossopharyngeal nerve, and our vestibulocochlear nerve. It's very important that we make sure these nerves are intact because a lot of these impact the airway. So we're always going to prioritize airway, breathing, and circulation. And the thing with these four of our nerves is that if there's any issue with these nerves in which they're no longer intact, this becomes a priority. This becomes a safety concern. Okay. So moving along, when we're doing our full neurological assessment, we're assessing the eyes, we're assessing the pupils. We want them to be 3 to 5 millimeters in size, and we want them equal, round and reactive, and accommodating to light. We want to make sure that when we're looking at our patient that their pupil isn't blown on the left side. Let's say it's, 6-7 millimeters, and then the pupil on the other side is 1. We might start thinking maybe there's some sort of hemorrhagic stroke happening, etc. We also talk a lot about posturing, and we're going to get back to this in immunological nursing. However, it's important to know what might be happening. So when someone has decorticate rigidity, these patients will be very rigid, and their hands will be clenched and curled inwards to the body. Okay, this is posturing. Posturing is a very, very bad sign, and it is a priority finding. Okay. Up next, we have decerebrate posturing, and essentially both of these indicate some sort of damage to the brainstem. Well, with decerebrate posturing, the toes will be pointed down and arched back, and the hands, instead of being curled inwards, will kind of be curled outwards. We also look at what our Glasgow Coma score is. A goal is going to be 15. If a patient scores a 3, it means that they are brain dead. For GCS, just remember you cannot score a 0 for a Glasgow Coma scale. So even if they really have no eye response, no verbal response, no motor response, they're going to get a 1 for that category. Okay. Eye response has 4 points, verbal response has 5, and motor response has 6 points. Are they alert and oriented spontaneously, or do they require verbal stimulation? Are they confused when they're talking? Are they even talking back to you? Do they respond to painful stimuli? All of this helps us get a better assessment of what's going on with our patient, and we're concerned about trends. Upon the start of admission, was our patient's GCS 14, and now all of a sudden it's 8? That's going to be a priority finding. Some common diagnostic procedures we'll see. Lumbar puncture is very common. It helps us kind of diagnose any sort of infection in the body that might be affecting the brain. How we are going to prep for lumbar puncture is we tell the patient empty their bowels and bladders beforehand. We're going to have them either lay on their side with their knees pulled up for the test, or if it's a pediatric or baby, you can kind of have them sitting upright and hunched over. But for the most part, we have the patient lay on their side with their knees pulled up and in. And after the lumbar puncture, we're going to increase fluids. It's important, if your patient is going down for an MRI, that we remove all metals beforehand, and we're screening for any sort of metals in the body, specifically pacemakers. For CT scan, our priority is going to be assessing for allergies and just really making sure our kidney function is optimal. Contrast dye is very, very harsh on the kidneys. So those are just some general things we want to be, aware of. For a cerebral arteriography, it's important we keep the patient NPO 4 to 6 hours before and after the procedure. We're really minimizing movement, okay? Your patient might experience some warm flushing of the face. That is normal. EEGs assess for seizure-like activity. Basically, they stick little electrodes kind of on the skull and monitor. It's important before this test that we're holding psychiatric medications and caffeine before the test, as it can interfere with results. For surgical procedures, first thing we have is our laminectomy. A lot of times it's called a LAMI, but essentially this removes a piece of vertebrae to help aid in decompression. So if a patient has like a T12 compression fracture, they can remove that piece to help prevent and essentially to decompress. And when we decompress, we're reducing that pressure and aggravation on the nerve. However, our concerns are, where is the piece that we're taking out located? If we're removing a piece of the cervical vertebrae, our concern is airway. If we're removing a piece of our thoracic, we're concerned about like our cough, our gag reflex, and bowel functions. And then if we're removing a piece from the lumbar portion of the spine, we're concerned for bladder issues, okay? Post-op LAMI, it's very important that we log roll the patient. We're not having the patient dangle their legs, and we're teaching them not to bend at the waist and not to lift anything heavier than 5 pounds. A discectomy, on the other hand, is going to remove the discs that are in between pieces of vertebrae. Same thing with our spinal fusion, all rules apply. This is often done for patients with scoliosis. It's very important that we, again, log roll the patient. The patient will be fitted for a brace, and they need to be wearing that brace about 23 hours out of the day. Up next, we're going to talk about head injuries. Head injuries can be quite complex, but we're going to break it down. So what are common types of head injury? We have concussions. These have very mild symptoms. There's going to be no visual loss. Contusions are more serious. They can have vision loss. When we talk about a diffuse axonal injury, this is shearing, often caused by motor vehicle accidents. Skull fractures are also common. The issue is that this can lead to a brain break or a cerebrospinal fluid leak. And patients with a skull fracture will often present with raccoon eyes. Hematomas, we have our epidural hematoma or a subdural hematoma. Essentially, what's a hematoma? It's a brain bleed. If it's an epidural hematoma, these patients often have a brief loss of consciousness, followed by a lucid interval, but then they're going to rapidly deteriorate. It's very important that we recognize these clinical findings. These patients will require a burr hole procedure where they're going to help drain that blood out, okay? Brain is a closed box. If blood begins to pool and pool and pool into the brain, we are now essentially squishing the brain. When we squish the brain, that's when we can have brain damage, we can have stroke, things like that. A subdural hematoma, they have symptoms, but remember, they have later onset. Usually patients will present with a headache, and then you'll start to see a gradual deterioration. The goal for a subdural hematoma is to reduce and prevent increased intracranial pressure, which we are going to talk about in a few slides. Remember, the brain is very finicky, it's very particular. Oftentimes, it's not a one-size-fits-all. You will have different signs and symptoms depending on what part of the brain is affected. So, up first, if we have any occipital injury, an injury to the occipital lobe, these patients will experience visual disturbances. If we have any injury to Broca's area, these patients will have difficulty talking, more specifically expressive aphasia. They want to talk, they know what they want to say, but it's just not going to come out, okay? Most often patients, you'll ask them a question or you'll ask them, what day is it? And all they'll respond with is yes. They're just having a hard time expressing what they're trying to say. With Wernicke's area, these patients will have difficulty understanding. They'll have receptive aphasia, where, excuse me, you'll be talking to them and they'll just be having a very, very, very hard time understanding what you are saying. For this, it's very important we ask simple yes or no questions, we be calm and patient, and we provide pictures to help. If there's any injury to the parietal lobe, these patients will have an odd perception to touch. Any injury towards the cerebellum, these patients will have tapping of fingers and toes, odd coordination, and just overall gait imbalances. Alrighty, so now we get to talk about increased intracranial pressure. This is always going to be a priority finding in any sort of question, any sort of situation. Increased intracranial pressure is priority, okay? What are signs and symptoms of increased intracranial pressure? We'll have altered level of consciousness, odd pupils, nausea and vomiting, specifically Cushing's triad. Cushing's triad is absolutely a priority finding. These patients will have bradycardia and hypertension with a widened pulse pressure. They'll also have very irregular respirations. Additionally, with increased ICP, patients have a hard time regulating their body temperature, so often they will either need to be heated or cooled. What are our nursing interventions? We want to keep the head of bed elevated, keep their neck aligned in a neutral position. We want to prevent increased carbon dioxide levels. Therefore, these patients might require a BiPAP or intubation. We want to make sure that they are on strict intake and output, and induced hypothermia can help. What medications? First of all, we want to avoid opioids or sedatives. If we need to put the patient into a therapeutic coma, we can give them barbiturates. Patients having a fever, acetaminophen. Steroids, specifically mannitol, is going to be very, very important. Well, steroids help with the swelling. Mannitol is a diuretic that's going to help reduce kind of that buildup of fluid in the brain cavity. However, with mannitol, we need to assess for pulmonary edema. That is a big complication of mannitol. Alrighty, my friends, now we get to talk about some other common neurological disorders. Up first, we have seizures disorders. Just know that there's multiple different types of seizures. Most often, patients will have an aura, such as metallic taste. What are our nursing considerations? It's absolutely going to be seizure precautions, making sure that there is suction at bedside, that when the seizure starts, we're noting what time it starts. We've got suction at bedside. We're going to put the patient on their side. We're not putting anything in their mouth. Afterwards, we're giving them some extra oxygen just to help. And if you have seizure during pregnancy, lamotrigine can help. The issue with seizures is that they can progress to SE. This is a seizure that lasts longer than 5 minutes. Why is this such a concern? If someone has been seizing for 5 minutes, they're probably not able to oxygenate as well as they should be. In this case, we're going to give them some medications such as lorazepam and diazepam. You can also mix phenytoin, which is Dilantin, with 9% normal saline. Assess for bradycardia as well. Hyperthermia is an issue because as the core body temperature goes up, it can damage pretty much all of our organ systems. And if you have a patient that's having hyperthermia, essentially patients with maybe neurological disorders or increased ICP will have a hard time regulating their core body temperature, which can then result in hyperthermia. Specifically like cerebral edema, issue with meningitis, it can cause cerebral edema. And as we have swelling in the brain has, specific areas that help with thermoregulation. So that's kind of why hyperthermia is grouped into neurological disorders. Obviously, these patients will have an increased temperature, but they will be shivering. How do we treat? We cool the patient, we rehydrate, and we put them on seizure precautions as well. Benzodiazepines help. We can give diazepam and chlorpromazine to help with shivering. Now we're going to move into our strokes. We have our TIA, transient ischemic attack. This is a mini stroke. It has reversible damage. And the symptoms do resolve. Therefore, our priority is going to focus on smoking cessation, lifestyle changes, making sure we're putting them on some sort of anticoagulant therapy, such as Plavix, aspirin, or warfarin. If the patient has an ultrasound of the carotids done and the carotids are stenosed or there's blockage, That often causes a TIA. You can do a angioplasty to help. However, if your patient is exhibiting signs and symptoms of a stroke, always check their blood sugar because hypoglycemia can mimic symptoms of a stroke. So what is a stroke? This is a cerebrovascular accident. We have essentially somehow starved the brain of oxygen, whether it be ischemic because of a clot or whether it be hemorrhagic because of a bleed. If it is an ischemic stroke, it's very important that we give TPA within 4 hours of symptom onset. And we are aware of some of the contraindications for TPA administration, such as active bleeds in the body or bleeding disorders. Some of our concerns post-stroke is going to be dysphagia. Oftentimes, physicians will put in orders for permissive hypertension, meaning if the patient has a blood pressure of 165, we're not going to want to treat that blood pressure because it's going to help us perfuse the brain, which is really good. Again, airway and dysphagia are our priorities, so we're just going to want to make sure we're monitoring that. Up next, we have a ruptured cerebral aneurysm. Again, another priority finding. The patients will report having the worst headache of their life. And they'll have some nausea and double vision. Treatment is immediate surgery. Alrighty, up next we get to talk about the spinal cord. So when we have any sort of spinal cord injury, severity, outcomes, treatment, essentially are all dependent on where the injury is located. If someone has an injury to the cervical area, we're concerned for quadriplegia and respiratory compromise. Any issue or injury towards the thoracic spine can result in paraplegia. And any injury to the lumbar portion can cause some genital dysfunction, bowel and bladder issues, and some lower extremity weakness. There's many complications involved with having a spinal cord injury. First is going to be our spinal shock. Essentially, it's going to be flaccid paralysis below the level of injury. Why are we concerned? Well, if we have an issue again with that cervical spine, we're concerned that this could result in respiratory paralysis. Up next is neurogenic shock. These patients will present with bradycardia and hypotension, issues, really monitoring and managing their core body temperature. Treatment for these patients is going to be atropine, dopamine, or pacing to help bump up the heart rate. And then up next, we have autonomic dysreflexia. This is caused by a stimulus below the lesion, which results in bradycardia and hypertension. Treatment is going to be removing the stimulus, making sure the head of the bed is elevated, and giving antihypertensives. Alrighty. Up next, we have multiple sclerosis. This is an autoimmune disease that creates plaque on the neurons. These patients often present with gait imbalances and spasticity. Treatment for these is going to suppress the immune system, so things like steroids, corticosteroids help. Baclofen is a really good muscle relaxer, etc. Up next, we have Parkinson's disease. This is caused by too much acetylcholine and too little dopamine. These patients will present with their Parkinson's shuffle. They are at huge risk for aspiration. This is treated with levodopa and carbidopa and some anticholinergics. Up next, we have ALS. Really, the cause and the cure is unknown. These patients often have fasciculations of the face. Eventually, death occurs by respiratory compromise. You can give Riluzole, Rilotec, and Baclofen. It's not a cure, but it can kind of help a little bit. Up next, we have Bell's palsy. This, a lot of times, patients come in with Bell's palsy and they're thinking that they're having a stroke because they're having that, facial paralysis on one side. They'll have some asymmetrical facial movements. Specifically, these patients have a loss of the nasolabial folds. It's important to place an eye patch on the affected eye. Up next, we have Huntington's disease. This is an autosomal dominant disorder that causes too much dopamine, leading to chorea movements. Eventually, it leads to respiratory compromise. There is no cure, so it's important that if this, a parent or somebody has this disease, that they get genetic testing done. Up next, we have Guillain-Barré. This is an autoimmune reaction from an infection. So essentially, patient has an infection earlier on and their body goes haywire. Patients will experience excruciating back pain, ascending weakness, altered blood pressure, heart rate. The treatment is supportive, possible ventilation, and then IV immunoglobulin. Wernicke's encephalopathy can occur due to chronic alcoholism that causes psychosis. These patients will often have confusion, ataxia, and treatment for this one is going to be thiamine. This often results from a thiamine deficiency, which again is chronic in our patients with chronic alcoholism. Alrighty. Last but not least, we have our myasthenia gravis. Myasthenia gravis is essentially caused by an autoimmune response in the body. It's an autoimmune disease. Causes weakness with activity, some difficulties with seeing, chewing, etc. Treatment for myasthenia gravis, eye care and artificial tears. We can give some pyridostigmine. However, the issue with this is these medications increase acetylcholine, which can then cause a cholinergic crisis. These patients will have hypotension and decreased respiratory rate. Our concern for patients with myasthenia gravis is that they can go into a myasthenic crisis, where they again have some decreased respirations, hypertension, and some weakness. Alrighty. Moving on from neuro, we're going to talk about disorders of the eye and ear. Up first, we're going to talk about the eye. Assessment-wise, we can use a Snellen chart to assess for nearsighted or farsightedness. And then tonometry also kind of uses the eyes to help us assess for increased intracranial pressure. Some common disorders, we have our retinal detachment. These patients often experience like hairnet vision, seeing floaters, or a curtain over the visual field. Treatment is going to be surgery. You're going to place a patch over the affected eye and just avoid pressure. Pretty much for all of these disorders, they require treatment, and post-op, we really focus on avoiding increased pressure of the eye. So avoid sneezing if you can. Don't bend at the waist. Don't bend down. Don't do cartwheels. Don't do yoga. Anything that can add pressure to the eyes. Please don't do that. With glaucoma, patients have gradual, vision loss, blurry vision. It's important that if you have a patient with glaucoma, we avoid anticholinergic medications. If a patient that has glaucoma reports immediate pain, this requires emergency surgery. This indicates an acute closure. With their acute primary angle glaucoma, these patients have, again, that pain, blurry vision, halos, etc. We're concerned that the optic nerve can, lose blood flow. The treatment is going to be timolol and surgery. Up next, we have macular degeneration. Essentially, patients will have blurry spots and blurry vision. This is chronic. If your patient has a foreign body, please leave it in the eye, and then we're going to shield both eyes to avoid movement. Our eyes like to move in tandem. If I tell my left eye to look left, my right eye is inherently going to follow. So shielding both eyes is important. Patients with cataracts, upon visual assessment, you'll see some cloudy lenses. Patients will report that they themselves see halos. Treatment is going to be surgery. It's important that we dilate the eyes before surgery. And again, we're doing everything to avoid that pressure on the eye. Up next, we have disorders of the ear. First, we have Meniere's disease. These patients experience nausea, vomiting, and vertigo. Treatment for this is going to be antihistamines. And then we can provide some education, such as decreasing sodium, decreasing caffeine, and decreasing tobacco. If your patient has hearing loss and requires hearing aids, it's important to know how to help them out with it. Teach them to pull the ear up and back to insert. If the patient hears a whistle in their hearing aids, means it's too loud, turn down the volume. When they need to clean their hearing aids, use an alcohol wipe. And please keep the hearing aids in their box and remove the battery at bedtime because we want to preserve battery life. Alrighty, moving on from eye and ear, we're going to talk about our musculoskeletal system. So at first, we've got some diagnostic tests. So if your patient is going down for an arthroscopy, it's important that we keep, free of infection. We're monitoring the site. Ice and elevation do help. If your patient is getting a bone scan, give the isotope 6 hours before. They must remain still for the scan. And because this isotope can be very harsh on the kidneys and the body, we're going to want to flush with IV fluids after the test. DEXA scan helps us screen for osteoporosis. It's very important before the scan that we remove metal. And if the patient is taking calcium and vitamin D, we halt that 48 hours before the test. It can interfere with the results. Up next, we have an EMG. This helps us measure muscle response to nerve stimulation. This is often used to help us diagnose many different neurological disorders, such as ALS, Guillain-Barré, myasthenia gravis, and carpal tunnel. However, for this, we use, essentially, they're kind of making little like needle sticks in the body. So just assess the site afterwards. For an MRI, again, it's important to remove all metals before the test, and we're asking the patient about metal stents and pacemakers. Alrighty, what are some therapeutic procedures? A lot of times we see an arthroplasty. If it's a hip arthroplasty, make sure post-procedure we're using an abductor pillow. We're teaching the patient not to bend or flex at a 90-degree angle. Avoid positioning on the surgical side. If your patient has a knee arthroplasty, we're going to want to help promote blood flow to the area by using a continuous passive motion device. Post-procedure, regardless, it's important we focus on early ambulation to decrease the risk of DVTs. We make sure to assess the drainage for signs and symptoms of infection. And oftentimes these patients will require narcotics or a PCA pump to help with pain management. If your patient requires an amputation, it's important that not only we perform a physical, but also a psychological assessment. When we're wrapping this area, we're going to use aseptic technique, and we're going to use a figure 8 dressing. Issues with amputations, big complication is going to be hemorrhage, infection, and phantom limb pain. For phantom limb pain, we can give calcitonin, we can give beta blockers if the patient has dull pain, anti-epileptic drugs for stabbing pain. And then flexion contractures can also occur. To prevent this, if they had a below the knee amputation, avoid using pillows to elevate the extremity, as that can cause the contractures. Up next, we have fractures, many different types of fractures. It's not important to know how to distinguish, each of these fractures. Just know that if you're dealing with a patient that's had a fracture, we want to be assessing the 6 Ps: pain, pressure, paresthesias, paralysis, pulselessness, and pallor. Okay, big complications. First off, we have a fat emboli. These patients will present with tachycardia, chest pain, petechiae, dyspnea, and tachypnea. More common in any sort of hip or pelvic fractures. They have a lot of fat around those bones. Up next, we have compartment syndrome. These patients experience severe pain, pallor, and cyanosis. They're going to have a hard time moving the extremity. Treatment for this is going to be a fasciotomy, where they physically relieve that pressure by cutting open the area. Afterwards, keep the extremity at the level of the heart. For these fractures, make sure we know kind of what we're doing in terms of treatment, what we're dealing with. If the patient requires a cast, please elevate the extremity. Never put anything in the cast. If the patient is very itchy, they can use a cool hair dryer. There's also traction that can be used. If someone is in cervical traction, this kind of helps with any sort of like head injuries. Bucks traction involves pulling, using weights, and regardless, have the patient maintain a neutral position. If the patient requires external fixation, this utilizes free hanging weights. It's very important that we prioritize early mobilization. And when they're in the external fixation, we're never grabbing at the device. We're not grabbing the device to help the patient lift their leg. Okay, we're going to go up, we're going to go above that. Alrighty. Moving into our musculoskeletal disorders. Up first, we've got osteoarthritis. This is normal wear and tear Patients often complain of nighttime stiffness, pain, unilateral. Treatment for this is going to be rest, ice, heat, and NSAIDs. Often surgery can help. Rheumatoid arthritis, on the other hand, is wear and tear caused by an autoimmune disorder. These patients have bilateral morning stiffness, warmth, redness, and swelling, but it's going to be bilaterally. These patients will have swelling almost, in all their joints, unfortunately. Treatment is going to be any sort of like DMARDs, meaning like anything that can help with the, body's immune system. Plasmapheresis helps, and a synovectomy can help. Gouty arthritis is caused by buildup of high purine foods. These patients often have high uric acid levels. It's important for them that we teach them to increase fluids and decrease the purine foods. Colchicine and allopurinol and NSAIDs are our drugs of choice. Up next, we have osteoporosis. There's many risk factors for osteoporosis, such as frequent steroid use, Cushing's, certain antipsychotic psychiatric medication uses as well. Teach the patients to increase calcium and vitamin D and to avoid magnesium. All right. Up next, we have osteomyelitis. This is an infection of the bone. It is very, very serious. Treatment is often long-term. These patients will be sent home with a PICC line to continue long-term IV antibiotics. Up next, we have rhabdomyolysis. This occurs when the body essentially breaks down muscle, which leads to toxic buildup in the bloodstream, often caused by dehydration or extreme exercise. These patients will be very fatigued, have a lot of muscle pain, and tea-colored urine. It's very important that we aggressively rehydrate these patients. Beautiful. Moving on to our integumentary nursing. Not a lot of disorders, but we'll cover the main ones. Just be aware of how we stage pressure ulcers. It's very important to prevent pressure ulcers that we're, turning our patients that need to be turned. We're moving them. We're assessing them daily for skin breakdown. We're making sure their skin is not wet, etc. If someone has an unstageable pressure ulcer, this means we can't see the bottom of it because it's covered in either like a black eschar or pus. For skin cancer, we use our ABCs to kind of not diagnose, but to really assess. So first thing you'll see is some asymmetry, some border irregularities, color changes, large diameter, and it will be evolving. Risk factors include a UV exposure and immunosuppressants. Up next, we have psoriasis. This is an autoimmune disorder. How do we kind of treat this? By, suppressing the immune system, also decreasing stress and alcohol. Teach the patients, to pat dry, and UV light can actually help. And finally, we have toxic epidural necrolysis. A lot of times in pharmacology, everyone is like, be careful, this can cause Stevens-Johnson syndrome. What is Stevens-Johnson syndrome? That is TEN, toxic epidermal necrolysis, often caused by a reaction to medications. Treatment for this is going to be eye lubrication. We're going to do sterile moist dressings, and the patient will be in a reverse isolation room. Alrighty, now we get to talk about burns. So how do we stage our burns? It's a first-degree burn. This doesn't involve any sort of blistering. It's more often our sunburns. A second-degree burn will have blistering and a loss of the first few layers of skin, such as the epidermis and dermis. Patients with a third-degree burn these can be deep partial thickness or full thickness burn. And with a fourth-degree burn, essentially they lose all layers, okay? It's also very important we know the rule of nines and we know how to determine what percentage of the body is burned. So we're gonna add. So the front and the back of the head is 9% of the body. The patient's back is 18% of the body. The patient's chest is 18% of the body. The perineum is 1%. Then we have to figure out the extremities. So we've got the right arm. The front and back of the right arm is 9%. If someone is only burned, though, on one side of their arm, that's 4.5% of the body. Same thing with the left hand. The legs are the same concept, but remember, we have more legs than we do arms. So if someone's entire left leg is burnt, that is 18% of their body. But if just one side of their leg is burnt, that's only 9% of the body. We're going to add up which areas are burnt. So let's say the patient's, back is burnt and the back of their bilateral arms are burnt and the back of their bilateral legs are burnt. So let's add it up. We have 18%. Okay. Then we have, the back of the right arm, 4.5, back of the left arm, 4.5. That's going to end up equaling 9%. So we take the 9, we add it to the 18, we're at 27% of the body. Now we have the back of both of the legs. So we've got 9%, which is the back of the left leg, 9% back of the right leg. Now we are again back at the 18. So we add the 27 and the 18 together. That's going to give us the percentage of the burn. Okay. Why is it important we know the percentage of the burn? For the Parkland IV formula, and you will be expected to know what the Parkland IV formula is. Essentially, we need to give 4 milliliters per kilogram per percent of the burn. So if 18% of the patient's body is burnt and they weigh 50 kilograms, we are going to multiply, I already forgot how much, okay, my bad, my apologies. But let's say 18% of their body is burned, they weigh 100 kilograms. So we're going to multiply 18 times 100 times 4. Whatever that total gives us, we're going to divide it by 2. Okay, that number is going to give us the first bolus, which we're going to give over 8 hours. And then that number we're going to use again, but now it's going to be given over 16 hours. So we double the speed the first 8 hours, then we cut that in half and we give it over the rest of the 16 hours. Always deduct what was given in the ambulance. We don't want to put these patients into fluid volume overload. What are our nursing interventions for patients with a burn? We want to make sure, first things first, we're protecting the airway. We're giving them humidified oxygen, keep the room warm. They're at risk for hypothermia. Even though they've been burnt, hypothermia is a big risk because their body is going to work extra hard to try to cool itself off, and they're going to be, quite dehydrated as well. Again, we are giving mass fluid resuscitation, so we want to make sure that the kidneys are functioning properly. Again, our normal urinary output is 30 to 50 mLs an hour. We want to make sure we are maintaining that. For healing, calories and protein are essential. If the patient's unable to, take in nutrition, they might need another form of nutrition, like enteral nutrition. Fluids and pain management help. Silver nitrite soaks or cream help as well. Mainly, we've got a lot of complication involved with burns, such as compartment syndrome, hypovolemic shock, malnutrition, respiratory failure, and sepsis. So we're monitoring our patients' vital signs, making sure that they're stable. It's very important that they elevate the affected extremity and doing like exercises and stretches, increase calories and proteins for healing. If the patient experiences itching, a cool bath and loose clothes help. When they're kind of having rehabilitation of the skin and wounds, water-based lotion helps. Active range of motion, avoiding the sun is essential. And they will be prescribed a compression garment, and they're going to need to keep that garment on for about 23 hours a day. Different types of burn dressings. We have our open exposure dressings. These help promote drainage, but are often very painful. Closed burn dressings unfortunately cause decreased mobility, which in the long term can have compromises on the patient's mobility moving forward. If the patient receives a homologous graft, this comes from another human. If they get a xenograft, this comes from an animal, like a pig. We are concerned about fluid shifts post-burn. Within the first 24 hours, these patients will start to see some increase in white blood cells, some, increased potassium, decreased sodium, etc. After the first, 48 hours, you might start to see edema in these patients and some metabolic acidosis. That's why it's important with the Parkland IV formula that we're deducting what was given in route. Alrighty. Up next, we are going to talk about hematology. Again, it's important to know your normal hemoglobin, normal hematocrit. Normal hemoglobin is about 12 to 18. Normal hematocrit is about 37 to 52. So, patients with anemia, lots of different types of anemia, but kind of across the board, they're going to, have some pallor, maybe some decreased H&H, hypoxemia, and just feeling short of breath. If patient has renal anemia, the treatment is going to be erythropoietin. Remember, if H&H is elevated, we hold erythropoietin. Iron deficiency anemia, these patients will require iron supplementation, or if it's caused by a bleed, we're going to stop the bleed. Aplastic anemia is caused by bone marrow suppression, and essentially they will be lacking everything. They will just have across the board low blood count levels. Treatment for this is going to be immunosuppressants, chemotherapy, possible stem cell treatment. And finally, folic acid deficiency anemia is going to be treated with folic acid replacement. For B12 deficiency anemia, this is either caused by diet or absorption issues. These patients will require B12 injections for life if it is simply a malabsorption issue and their body just can't absorb B12 through the stomach. If it is a diet issue, they might, require supplemental vitamin B12. For polycythemia vera, these patients have too many red blood cells being produced, causing their blood to be thick and viscous, putting them at risk for DVTs. Alrighty. Up next, we have our hemolytic anemias. Essentially, when the body can't increase production enough to make up for early destruction of red blood cells. Treatment is going to be the underlying cause, possible blood transfusion. So for patients with sickle cell anemia, this is a chronic condition, inherited condition that unfortunately gets exacerbated in times of stress. The treatment for this is going to be hop to it. We give hydrate, IV fluids, we're going to give oxygen, and pain management. Morphine is the drug of choice. Hydroxyurea can also help. The thalassemia, this happens when the body makes abnormal hemoglobin and the body responds to this abnormal hemoglobin by destroying it. Okay. Treatment for this is going to be folate and folic acid. These patients will require regular blood transfusions, and they may need chelation if they have excessive iron. Because when the body breaks down all of these hemoglobin, we've got all this excess iron that's kind of just hanging around. Alrighty. Some other hematological disorders, we've got hemophilia. This is an X-linked recessive disorder, therefore it's more common in males. Essentially, these patients have difficulties with clotting, blood clotting. So after an injury, it's going to take them a lot longer to heal. For these patients, avoid the use of NSAIDs, and we're going to rest, immobilize, cold, elevate for injuries. Up next, we have thrombocytopenia purpura. This is a reduction in platelets, which essentially leads to increased bleeds. Report a altered level of consciousness in these patients. This is often a symptom that there is a bleed. Okay. For DIC, this is a clotting disorder that is caused by a response to sepsis or trauma. Essentially, it causes massive clotting, which then leads to no clotting at all. Patients, upon like a visual assessment, you'll see some rash, some red spots. These patients will start to have altered level of consciousness. Treatment for this, we need to identify what's going on, what's the underlying cause. Is it sepsis? Is it trauma? Let's treat it. We can also give them anticoagulants to help break up those clots that have already formed to help try to release them, and some fresh frozen plasma. Alrighty, now we're going to talk about blood transfusions. So, if a transfusion reaction occurs, immediately stop the fluid or stop the infusion. We flush it with normal saline, then recheck vital signs. Always, 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 first thing we do, stop the infusion. It's important that before we give blood, we do a full set of vitals, including blood pressure, heart rate, respiratory rate, and temperature. If your patient starts, you start seeing changes in their vitals, they start breaking out, they start, feeling anxious or whatever, stop the infusion. Okay. For a hemolytic transfusion reaction, these patients will present with hypotension, fever, and chills, and some flank pain. For an anaphylactic transfusion reaction, these patients will present with hypotension, hives, and angioedema. And for a febrile transfusion reaction, these patients will present with fever and chills. Again, regardless of what's going on, stop the infusion, flush with normal saline. Alrighty, for nutrition, kind of in our hematology area of things, what are some iron-rich foods? Well, first we've got fish and organ meats, enriched and fortified foods, whole grains, dry fruits, and egg yolks. Remember, if you're trying to increase iron, pair it with vitamin C. Vitamin C helps aid in iron absorption. If we're trying to increase folate in the diet, dark greens are the way to go, leafy vegetables, beans, legumes, and citrus fruits. Alrighty, my friends. Up next, we're going to talk about oncology nursing, many different types of cancers. We won't go too into detail about the types. Nursing is generally the same. Lots of different risk factors. Unfortunately, these patients can have lots of pain, issues with immunity, etc. What are our signs and symptoms? We like to use caution, stands for change in bowel or bladder habits, a sore that won't heal, unusual bleeding or discharge, thickening or lumps, indigestion or difficulty swallowing, obvious skin changes, nagging cough or hoarseness. We can also assess patients' lymph nodes. Ideally, they should be soft and mobile, less than 2 centimeters. If they are firm and immobile or greater than 2 centimeters, that is a concern. We might be, suspecting something. Alrighty. For patients with breast cancer, they can undergo a mastectomy. This is full removal of the breast tissue. For patients with breast cancer, it's used in combination with chemotherapy. Priority is going to be elevating the extremity to prevent lymphedema. It's important that if they had, their left breast removed, we're elevating that left extremity and we're not doing any sort of needle sticks or lab draws in the affected arm. For patients that have Hodgkin's lymphoma, they present with painless enlarged lymph nodes, fever, diaphoresis. Lots of concerns with Hodgkin's lymphoma are superior vena cava syndrome, but specifically tumor lysis syndrome. This causes a dangerous electrolyte imbalance, can result in acute kidney injury. Our treatment for tumor lysis syndrome is going to be rubicates, because this can cause hyperkalemia. Our treatment for hyperkalemia is IV dextrose and insulin. And any calcium imbalances can also cause seizures, so we put them on seizure precautions. Our main focus, though, for oncology is going to be chemotherapy versus radiation. We talked a lot about this in our fundamentals of nursing. But chemotherapy, just know that patients undergoing chemotherapy are at risk for infection because this drug does tank the immune system, can cause lots of nausea. So giving them, medications beforehand is very helpful. A lot of times they complain of mucositis and stomatitis, so making sure that we're doing proper oral care. If your patient is getting the chemotherapy medication doxorubicin, just understand that this can cause cardiac issues, so we're going to want to make sure we're monitoring their EKGs. For radiation, lots of different types of radiation. It's just important that if a patient receives radiation to an area of the body, that they are properly taking care of the area, avoiding direct sun exposure. Patients receiving radiation will require a private room. Make sure that you keep tongs at bedside, and that when you are in the room that you're wearing a lead apron. If the patient has visitors, they should be limiting their visit to 30 minutes and stay 6 feet away. All right. Up next, we're going to talk about HIV. For patients with HIV, you've got the acute stage, often present with a fever, kind of just not feeling very well. And swollen lymph nodes, might think they have the flu or something. These patients will have a high viral load, but their CD4 count will still be high. It will be 500. Remember, our CD4 cells are our infection fighter cells, and the issue with HIV is that it attacks our infection fighting cells, which then put the patient at risk for infections. And unfortunately, they often die because of these infections, not because of the disease itself, but because the disease attacked our immune system. For a patient with latent HIV, they will have the positive HIV antibody, and their CD4 count will be between 200 and 499. If the patient progresses to AIDS, essentially their CD4 count is less than 200. It is very low. They no longer have the ability to fight infections, so they're going to have these rare infections, like opportunistic infections such as tuberculosis, cytomegalovirus, and Kaposi sarcoma. For testing, it's important that 3 weeks after potential exposure, they get an ELISA test, and they follow up with a Western blot test. What are some treatments? We can do pre-exposure prophylaxis for at-risk individuals. Post-exposure prophylaxis, such as tenofovir, helps. And then if the patient is not pregnant, they can get HAART. Alrighty, up next we have SLE. While the cause is kind of unknown, these patients often always present with like a butterfly rash, fever, malaise, positive ANA. A lot of the complications with SLE is it can cause damage to lots of areas in the body, such as our kidneys, respiratory system. It's important we teach these patients to rest because of all the issues it can have, with the skin and the bones and the joints. Sunscreen helps, mild soaps helps. Medications suppress the immune system. We've got NSAIDs, corticosteroids, methotrexate, and hydroxychloroquine. Those are our DMARDs. Okay. And remember, with these medications, they will also suppress the immune system, patients at risk for infection. So we focus on, please make sure that we're washing our fruits and vegetables. We're not eating raw fruit. We are, avoiding large crowds, things like that. And we'll talk more about that in our pharmacology review. Alrighty. Up next, we have Sjögren's syndrome. These patients essentially have very dry mouth, very dry skin, and urinary retention. Treatment is going to be focused on, supportive comfort measures like artificial saliva and oral lubrication. Up next, we have scleroderma. This is skin thickening. However, an issue with this, these patients can have renal crisis or malignant hypertension. For Kawasaki's, this is often caused by infection. These patients will have a red rash and strawberry tongue. Complications later on in life is that this disease can cause damage to the joints and cause arthritis. Up next, we have meningitis. It can be viral or bacterial. These patients will present with the Brudinsky sign or the Koenig sign. Our whole goal for meningitis is to decrease stimulation. For patients with acute rheumatic fever, they will present with rash and involuntary movements. Our concern is going to be some cardiac complications. Talk more about the acute rheumatic fever in our pediatric review. Alrighty, and last but certainly not least, we have our critical care nursing. Just a couple, numbers to be aware of. We have our CVP and our POP. If both of these are elevated, the patient's having some overload of fluid and we're going to want to diurese them. What happens with third spacing? If your patient experiences third spacing, fluid is going out of systemic circulation and will deposit into the body tissue. Therefore, they will have a reduced urinary output. You'll see hypotension, but you'll still see fluid volume overload. They'll have edema, but the blood and the fluid is not where it should be going. So it's not going to help any of the organs. It's essentially just depositing in the extremities. For hypothermia, our concern is cardiac dysrhythmias. It's important we keep the patient warm and cover their head. It's very important we also get 2 large bore IVs in to help with fluid rehydration and give them warm fluids. Malignant hypothermia is a reaction to general anesthesia. These patients will present with fever, hypercapnia, and muscle rigidity. The treatment for malignant hyperthermia is going to be dantrolene. For patients who have overdose, it's important that we make sure we get them a large bore gastric lavage within 1 hour and have emergency resuscitation equipment at bedside. For patients with frostbite, cover the area with a loose dressing and elevate the extremity. It's important we slowly rewarm the area and provide appropriate pain relief. If your patient has an impaled object, the priority is going to be stabilizing the impaled object first. Alrighty. For patients on a ventilator, ventilators are used if the patient requires PEEP for acute respiratory failure, respiratory distress syndrome. Essentially, it's going to help pop open the alveoli, which are the site of gas exchange. When we pop open the alveoli with the ventilator, it allows more areas for blood to kind of pass by and take that, oxygen, let the body use it, and send out CO2. For a patient on a ventilator, we're going to want to pause sedation daily for some ventilator sedation vacations. After extubation, frequently assess the airway and keep the patient NPO. Our concern is barotrauma and hypotension from PEEP. A big complication from ventilators is VAP, ventilator-acquired pneumonia. This is why elevating the head of the bed, taking sedation vacations, and frequent oral hygiene is very important for these patients. Post-CPR neuro injuries are also very, very common. If your patient required CPR and we got them back, we've got ROSC, return of spontaneous circulation. It's important we do a full neuro assessment. We're assessing the Glasgow Coma Scale. And kind of getting a picture of what brain damage there might be. What we can do for these patients is we can induce therapeutic hypothermia to help minimize brain damage. Alrighty, and in general, for critical care nursing, when in doubt, hold or stop the intervention or medication first, assess your patient, prepare to give an intervention, and call the doctor. If you have an unstable patient, call a rapid response for them. So that is all I have for the part 3 of 3 Medsurg review. I hope it was helpful, and if you guys need anything, please go ahead and let me know. In the link, there is a link to get the downloaded review.